Barakatuh. Please, we're going to start now the second theme of this basically conference. And this part is going to be like a expert panel workshop. And the discussion will be around coming up with the national action plan towards the Saudi Dementia Action Plan. So we discussed earlier throughout today and yesterday's basically talks and lectures that we recognize that dementia is such a priority for Saudi Arabia when it comes to delivering care. We also identified the several gaps that we would like to work to basically fulfill and close. And we also heard from the International Dementia Association that for each country there has to be either a national strategy or a national plan to address dementia, addressing multiple areas of action. So the theme of this discussion, we would like, basically it should have been more of a small group type discussion for experts. However, because of the structure of this theater, we will be focusing on the experts in the room who will basically help us develop the priorities, followed by the recommendations for each action area. So I would first invite you all to screen the QR code on the, screen. Following that, there will be several questions and multiple choices that guide us through the discussion. I will be walking by with the mic, so if someone can help me with the mic so I can go around and maybe interact with the experts in the room. The non-experts will be welcome to maybe listen, and later on at the end of this session, we might open the stage for some comments from the non-experts. However, we would welcome all the comments. Hopefully, we can incorporate this to the final statement or recommendation from the conference. Okay. So, if you have any difficulty with the QR code, or it's working fine. Okay. So okay, Dr. Is it not working? In some areas, it will ask you for basically for answers. That time, you will have the question in your phone. So you're not having, sorry, Dr. Did you try what's? Okay, awesome. Yeah, okay, so here is basically our problem statement. So the problem statement is that with the expected increase in life expectancy for Saudi people, we expect a significant increase in the number of people living with dementia. So our vision is to develop a comprehensive national action plan that promotes the health, wellness, and dignity for those living with dementia, and address and strive to reduce the population risk of developing dementia through a multi-sectoral approach using innovative state-of-art best practices. Okay, so this is for the experts. This will be our problem statement. So to start, so we can, yeah.
Let's get down to business. Give you one more night to get this. We've had a million nights just like this. So let's get down to business.
Okay, so just to start with the framework, so what we will start with first is to discuss the phases of the usually commonly used to develop a national action plan. So most of the action plans, it starts with planning phase, which should be the majority of this discussion today. So the planning, what goes in the planning phase, we usually establish like a steering committee in a, basically with the stakeholders owned by the body that actually puts forward the regulation. Commonly, this is left to the Ministry of Health, which I represent today, inshallah. And after the steering committee, so basically we do have a scientific committee in collaboration with the chapter of neurology and the Neurology Society. We will be focusing on the scientific part of the plan and also help develop the registry. So that's what we started basically a few months ago with having a memo of understanding to put forward this committee. So the second step would be assessing the current situation. So basically for the current situation assessment, based on the lectures and the studies that were presented yesterday, we should be able to come up with some of the major gaps, and I will talk about them in the next slides as well. The other part would be focusing on creating ownership and raising awareness. I think, honestly, from my personal experience, is that the big issue is with the ownership of either the plan and basically the sustainability and accountability of that owner. So sometimes when you allocate let's say, societies, they don't have the power to implement and basically mandate certain regulations. So hopefully and commonly like the ministries that has that mandate or provision is either the Ministry of Health or the Ministry of Social Affairs. So following the planning phase, we will focus on the development phase of the national plan by defining the goals, time frame, objectives and targets. So we can touch upon those elements today. The most important part that I'll focus on is setting the priorities. I think one of the attendees talked about like priorities in research, but it's also important to focus on priorities in practice and regulations and other areas that we should focus on, because each country has pains and certain pains compared to other countries. So what we have in Saudi is so different than what Qatar have, and even way more different than the Western societies and advanced parts of the world. The third stage would be the implementation stage. And when I say adoption of, this is basically short for Saudi National Action Plan Towards Dementia. So that's, so basically this is the abbreviation for that. The latter part would include integrating this action plan into an executive work plan and allocating budgets and communicate these activities with results to the bigger world or stakeholders. Finally, an action plan usually ends up by monitoring, frequent assessments and evaluation to sustain our national plan. So the, again, Saudi National Action Plan Towards Dementia, okay? So in short, these are the like big stages of planning a national plan. So I will start by, now this is the first question that should come to your screen. And please, I welcome all the experts in the room to rate what should be the highest priority areas for the National Action Plan in Saudi Arabia. So you can see that all these areas are very critical, very important, and they should, but for us, where do you want us to focus on? And after that, I will open the floor for discussion from the experts. And I will choose either randomly or from those who are interested. But again, if you allow me, this discussion is mainly for experts. Later on, we're going to take your, basically, your comments, okay? Dr. Roa is not around. I think we can call her. So usually leave like 2-3 minutes, and they will be sitting here to see the results. So, basically, this is mainly this part of any action plan should be should involve those who are experts in that particular field. So I don't think it's actually biased because that's what we want. Like you are the expert, you should make. And mashallah, we have good number, mashallah, of experts in multidisciplinary fields. We have geriatricians, so geriatrician from internal medicine background, family medicine background, neurologist, psychiatrist. We also have other from other fields such as PT and other allied healthcare. So so I'll leave it for a few minutes, sorry, a few seconds, and I think we can put it to rest. Okay, so I think based on what we have here in the slide, I think what most of you rate as the first priority is dementia diagnosis, treatment, and support, followed by dementia awareness and friendliness, dementia research and innovation, and lastly would be like support for dementia carers. And what we mean by dementia carers are those who are providing care for people with dementia. So allied health staff or family members or non-formal like caregivers, okay? So moving to the other part. So now since we established our, let's say, sequence of priorities based on the great contribution from our experts, we should now ask the question about what are the strengths of the Saudi health system towards achieving excellence in dementia care. Okay, so now that we prioritized our areas of, let's say, focus areas in the national plan, so now I'd invite you actually, those experts, please, everyone, if you can. This should basically be an open-ended contribution, so you can write your comments, and then I will pick basically from the front row seats. I invite speakers and experts to reflect on that question. Okay, so here are the experts. ممكن أبدأ فيك دكتور عبد الله. Is that okay? So the question is from your experience, what are the areas of strength that our current system has towards addressing dementia? So you can talk about it from any domain you want. You're talking about the infrastructure. You can talk about the training. You can talk about the tools. You can talk about basically either manpower or like innovative / technology infrastructure that can help or at least base the foundation of Saudi health system to address excellence in dementia care. Okay?
Thank you very much. I think one of the strengths in general of the current Saudi healthcare system is the fact that it's an evolving system. A lot of changes are coming and already started. So the environment, the culture is accepting, ready to accept changes within the healthcare system. So in general, I see it as a strength. I will add that in general, we have reasonably good family sort of healthcare support system. Need to be supported by more of governmental, social support system to support, these the families. The other strength when it comes to dementia per se is the fact that we are still in general a young population, and that's why dementia as an absolute number, as an absolute issue, it's there, but you cannot compare it to what's happening in other countries where the population is aging. So we have time to coordinate and work, trying to reduce the burden of the disease on our country over the next 5-10 years. So I see it as also an advantage that we have. Thank you.
Thank you so much for these amazing comments, and very well taken. And these are the kind of comments we're looking for. So we can share the mic between the experts. So Dr. Muhammad, you have an input, please.
يعطيك العافية Dr. Waleed. Absolutely. I think, your previous question in terms of ranking all those aspects for the national standards for what we want to achieve in dementia, really, if you had 1,000 inputs and you ranked them all differently, you'd be all correct, because they're all very, very important. So how do we choose? My recommendation is that we go for those that have the most impact with the lowest effort. And so in that sense, I somewhat agree with the ranking that we did already. I think the Kingdom has come a long way just in the past 3-5 years in terms of services provided towards countering dementia. And if you think about it, in the West where I trained in Canada, they would ask me how far along are we in providing these services for dementia and geriatric medicine. I'd say, if you had to give a number, look at the Canadian Geriatric Society. They've reached now the 42nd conference, right? And currently in Saudi, the SGS has reached the 2nd annual conference. So if you had to put a number, a rough estimate objectively, we are 40 years behind. Now, are we really 40 years behind in terms of what we're achieving? Absolutely not. And we're really jumping significantly year by year towards providing excellence in care. So I think, we have lots of low-hanging fruits in terms of, high impact, low efforts that we can achieve with these services. And I think right now the ball is hot in terms of all leadership in the ministry green-lighting lots of these projects. 5 years ago and prior, I'd say there's been some resistance or unawareness in terms of its impact. But I think right now it's essential to talk about these. I guarantee you, inshallah, in the next 5 years, you'll see significant services across the kingdom about dementia care and services.
Any contribution from other experts? I think usually people like to talk more about the challenges, but I will give maybe another minute or so. So, Doctor, if you have any contribution.
I'm just echoing my colleagues' points. I think risk reduction is one of the important aspects that we need to tackle as a community, as a country. 40% of Alzheimer's risk are modifiable, things that you can work on. And there is something called attributable risk factors or reduction. So, for example, decrease in hearing, it can reduce the risk of developing dementia by 8%. Increase the better level of education that we are getting now. This should reflect on the cognitive reserve of our population in the next 20, 30 years from now.
I just want to have a comment. So what do you think is the strength in the Saudi health system that would allow you to achieve these goals? What do we have now that you should build on? So that would basically assist you in fulfilling that goal.
I think what we have now, but we didn't have a few years ago, is a better family medicine care, better primary care centers. So I think reaching out to the communities now has been better than before. So I think this is one of the strength points that we should utilize to achieve a better prevention for Alzheimer's. As Dr. Najib Qadi said yesterday, just delaying the diagnosis of Alzheimer's by 5 years has a huge impact on the economy, on the health system, and so many aspects.
Okay, amazing. Any other contribution from our experts?
Yeah, I think the 3 points important in our healthcare system. The primary healthcare screening program now established, so I think this is one of the strengths. Second things, the home care cover all the kingdom, and there are many programs I know that focus on those population. The third thing, we have a lot of specialized geriatrician in all hospitals in the kingdom, but we need to join all this service together. We have like scattered service. We need to make them work together in order to achieve our goal.
Okay,
Thank you.
Dr. Slan, if you have anything, or we can...
no more point. I think I agree with all what have been said. Thank you so much.
Okay. دكتور تفضل.
أنا حقيقة بقولها بالعربي أحسن.
Yeah, go ahead.
القوة في نظام الصحي إن الاستفادة في مراكز الرعاية الصحية الأولية من الأقارب والأسر الموجودة في العائلة. يعني الوحيدين يتميز فيه نحن عن الدول كلها إنه ما زال عندنا الترابط الأسري مجتمع. أعتقد إن نسبة كبيرة جدا من الديمنشيا ما يحتاجوا دخول المستشفيات ولا يحتاجوا خدمات إنشاء في المنشآت، يحتاجوا أنك تؤهل وتدرب السبلينج الأقارب بالرعاية الاجتماعية اللي شوية نقول assistant nursing. لو استثمرنا في هذا، وإحنا عندنا ما زال في رباط والبر، استثمرنا إنه المراكز الصحية الأولية بانتشارها في الأحياء والقرى إنها تدرب الأقارب والأولاد الزوجة، سيمكن إنه يكونوا هذه قوة عاملة كبيرة يدفعهم البر والعلاقة بأنهم يتدربوا ويكونوا هم أداة لتحسين الحالة. شكرا.
يعطيكم ألف عافية. Now I think just because of the time's sake, we would like you guys to be out here before like 5 inshallah. So I will go for the next question. Then now you know the theme. So so the next question basically asks the following. So what are the weaknesses of the Saudi health system towards achieving the like excellence in dementia care? So I think a lot of people like to talk about weaknesses. So let's hear from our experts. You have maybe like 2.5 minutes or something. What's your good name? Wow, now it's becoming actually even more interesting. So just a few seconds ago, we heard that we have a strong primary healthcare system, and now we are seeing weak primary healthcare system. So now it opens the floor for discussion. So whoever wants to contribute first, I don't mind. Doctora? Yeah.
Thank you, Dr. Walid. Munabed, neurologist. So I'm going to be speaking on my point where I'm a neurologist, not my other job. So I think one of the biggest weaknesses we have is agreeing on a definition of dementia. Okay, I think when you want to look at how do we, like between neurologists, for example, geriatric psychiatry, geriatricians and family physicians, others, like the way we define dementia is different. Like you would see, no, I have Alzheimer's disease, I don't have dementia. And if you say they have Lewy body disease, no, they don't have dementia. And so I think that's a big thing. So then when you want to like code the patient in a system, then you can see all this differentiation of what, like, that's why you can't collect data, basically, if people are coding it correctly. The second part is fragmentation of care. So a patient could be seen in different centers by different specialists who give him different diagnoses, and we don't talk to each other. So I think that's a big one. And I think one of the main reasons maybe healthcare providers don't like dementia is because it's not a quick win. It's not like you're going to do, like, for example, do a big surgery, you like for heart transplant, and then everybody claps for you and people see you there, and there you're all over the place. Dementia requires patience, require longer office visits, require continuation of care for someone that you know is not going to get better in 10 years. Probably they're going to get worse in the coming 5 years. And this lack of big wins or fast wins or very obvious wins make our specialty sometimes looked at a bit down, because it cannot be a headline on a newspaper. Thank you.
Thank you so much. This is really great comments, Doctora. Okay, so for Dr. Fahad, what would you like to comment, please?
I would like to connect the three questions that were imposed on to make sense of how we can address this issue, and also link it with what was presented today. So what was presented today include the expected significant growth on our geriatric population, and for that reason, and with the prevalence of the risk factors in this country more than probably many other countries, I thought that the priority that should be addressed is risk reduction. If we address risk reduction, then we're talking about a potential to expect dementia to be a disease that we can kill eventually, if we can. Now, when we talk about dementia care, it entails an acceptance of the presence of the illness or the disorder as it is, rather than deal with its original causes. So I would love to be part of a strategy that looks at how we can kill that from the root, if I use these aggressive words, because if we don't, with the expected growth, it's going to be very, very difficult to manage a problem of that size, with that expected size of a growth, with the limited resources that will be available to us over a period of time. And this is the best time to intervene, because the expected growth in the geriatric population is in about a decade or two. If we're late, then we lose that chance.
This is amazing point, and true. It is actually a health dividend that we should capitalize on right on. So, so basically, any other expert would like to comment in the first row or for this basically part? So again, we're really focusing on the weaknesses of the system. So, because if you can identify a weakness, you can potentially try to fill that gap or fix it. Please go ahead.
Thank you. I see it as a. I'll start with the. I see it as a strength, and you know, we'll talk about weaknesses. The fact that we have Vision 2030, which is leading now our country, and many things that is being conducted in our country. And now we see it after 5 years. One of the strengths is the fact that the well-being of the community and the population is one of the main targets of Vision 2030, and healthy aging is another clear target of Vision 2030. These are potential strength of the healthcare system. On the other side, I think primary care in our country is improving rapidly over the last 5 years, but in my view, it's still weak, and the healthcare system is still fragmented. It's very clear, and this is also part of Vision 2030, improving primary healthcare services. That's why we see the focus and shifting the focus from secondary, tertiary care over the last 40, 50 years to primary care over the last probably 5 years, in my view, the real focus. That's why I see primary care is improving, but it's still weak and need a lot of work in order to improve on it. And I think primary healthcare services will be the first frontliner when it comes to dealing with risk factors and also early detection and management of dementia disease. Thank you.
يعطيكم ألف عافية. Let me maybe steer the discussion in another direction. So do you think that we have equitable care for people with dementia across the kingdom? Do you think we have access to the best care practice for people with dementia across the kingdom? Do we think that basically we have enough guidelines or enough regulations to support people with dementia across their continuum of care? And so basically these are kind of potential weaknesses that we should also focus on. So we can look at it from macro level, meso level, and micro level. So from macro level perspective, when was the last time you've seen like a national guideline for best practices, which is a necessity for like if we have as I can see here, there is also there is a mention that healthcare professionals are unaware outside geriatrics and neuro of the basis of dementia. The way to solve this from my or the weakness here would be basically absence of either enough training or sufficient training or at least some guidance or guidelines. So what do you think, Dr. Mohammed? Is that something that you identify as a gap or weakness?
Absolutely. I think the answer to the three questions you posed at the beginning is no, no, and no, but I think it's improving very quickly, as I said earlier. I think a guideline is an excellent point because the number one thing that you receive from primary healthcare or other caregivers in healthcare professionals, in other sectors, not in our field, tend to ask us to what they should do next. I trained in Canada, so I'm a bit biased. There is something called the CCC DTD5, which is a guideline study. It's excellent, very easy to read for other professionals not in the field that provide, what they should do for those with dementia. So I think if we have at least a first edition of that in the kingdom to provide to those professionals, it's going to really help, articulate and hasten the speed of these services across the kingdom.
It's great that you refer to the CCDT. So Dr. Sergey Gautier, he sits on that guideline. He's the head of the committee. He's our basically speaker yesterday from the first lecture. So I think that's why he was invited to that talk. So now let's move ahead to the third basically question, which states what are the opportunities that we can capitalize on to ensure a successful, sustainable implementation of the national plan. So I think Dr. Abdullah just mentioned the Vision 2030. So that would be one of an example of the opportunities. So it could be, we could start talking about like leadership support. We can talk about infrastructure that could potentially support the implementation of the plan. We can also address the number of expertise and so on, but I will leave the discussion free for the experts, and we'll take it from there. So the question is, what are the opportunities that would help us sustain and implement a successful national plan? So from my experience, I know that there had been several attempts in the past to either come up with a national strategy related to older adult health and related issues. But for now, what we should basically focus on in terms of opportunities to seize up the moment and seize up the opportunity to sustain our plan. Okay. Okay. Oh, wow. So we just had in the room our godfather of geriatrics in Saudi Arabia, Dr. Hashim. Welcome. Okay, so maybe I will start with Dr. Sultan, and we take it from there. So from your basically experience, what do you think the opportunities are that we should capitalize on?
I think, as Dr. Abdullah, as I mentioned, the current vision 2030 is the most important factor that can lead to success of this initiative. The other elements that you all see, for example, the infrastructures. We have good hospital and primary healthcare infrastructure. We have almost closing the healthcare continuum. We have the home healthcare, LTC or long-term care is increasing in the kingdom. So I think these are the most important factors, and also the elderly rights law will make this initiative a success.
Dr. Lo, if you can comment on that, like how can we use that law? And basically older adult law has so many articles in there that supports the development of the health system, and especially the actions and the services for older adults. And it also addresses so many things related to people living with dementia. So from the whole spectrum, prioritizing their care and so forth. So if you can comment on that, that would be a great actual point.
Let me first comment about the vision 2030 regarding the volunteer work.
ممكن تتكلم بالعربي دكتور إذا بغيت.
I think one of the big challenge we face is to create enough skilled personnel. And as you know, we cannot put all this load on the government institute and system. So I think one of our goal to empower and to enforce the NGO to work side by side with the government and the private sector. So if we can, I think one of the opportunity I find is the incorporate the NGO with the government to deliver the service regarding dementia. This is number one. Number two, as you said, that we now have the convention which came just 6 months ago regarding how we can protect the elderly people, particularly those with dementia or with disability. And I believe if we need these convention to be implemented, we should educate the family how they will be punished if they abuse these things, because unfortunately most of the people, they don't know about this is a convention. So one of the issue that we should launch a big awareness campaign regarding this is rules.
Who do you think should have this ownership, basically, to have this awareness campaign? Do you think it should come from the human resources and development affairs ministry, or should be like NGOs? And there's also one area, I think you might know this better than me. I know that there is currently an interest to basically make or actually invest in the NGOs by around 0.5% to 1% of the budgets. So I think it became like a provision, and it will be a provision across most of the facilities, ministries, and so forth, that they have to allocate part of their budget for NGOs to take care of some of their provision of care. Right?
Yes.
Yeah, so
now,
you can reflect on that.
The first actually suggestion came from the family councils that we already assign the Ministry of Education to launch. We believe that the best people to educate them is the young people, the student in the schools. They are the best one to care after their sibling from the elderly people with dementia or with other disability. So if we can actually train them from the beginning how they figure out the dementia cases, and then ultimately how they can give them the right service, then I think we will save a lot of things. Of course, it is the Ministry of Health, the Ministry of Social Affairs. But the second point, we mentioned that now, as we now in the what we call it the Health Society Council, we have now very clear vision that we should empower this society to work in the behalf of the Ministry of Health and Ministry of Social Affairs. So we just talked with the Princess Nov about that we want to deliver something for dementia. And I think with the supervision of Ministry of Health and Ministry of Social Affairs, and I think we can use all this is 300 health society all over the kingdom to just to go, because they are better than the government institute. They can go to the field, they can go to the home, and they can make a big difference and big value.
Okay. طيب دكتور, maybe I will say it in Arabic. كان في ورشة عمل مع وزارة الموارد البشرية إنه الآن الوزارات كل القطاعات تسند جزء من ميزانياتها للقطاعات غير الربحية للقيام بالأدوار. هل هذا الحين صار تشريع أو صار تنظيم إنه, وكم كان النسبة تقريبا من كل وزارة؟
يعني كان عندنا اجتماع قبل يومين في القصيم عن موضوع الجمعيات الصحية. أولا طبعا نظرا لأنه السنتين الماضية كان في حاجة البلد في قضية الخدمات الصحية وكورونا، خدمات المرضى وكبار السن وغيرهم اللي في البيوت اللي كانوا صعب عليهم يروحوا المستشفيات المراكز الصحية الأولية. احنا فوجئنا بالرقم إنه للآن المرافقة الحكومة أعطت لكل الجمعيات، أنا ما أتكلم عن الصحية، كل الجمعيات أعطتها عقد. كم تتوقع يا دكتور وليد؟ You don't believe it. أعطوا عقد في الثلاث سنوات الماضية 2 بليون و 200 مليون. 2 بليون. هذه يسموها الإسناد الحكومي لشراء الخدمات. وقالوا الآن نرغب إنه الجمعيات الصحية أنها تقدم، والآن طبعا صار في منصة اعتماد تدخل فيه الجمعيات الصحية وتسجل للخدمات. والآن طبعا عشان كذا نحن الآن في مجلس الجمعيات التخصصية الصحية بنسعى إلى تأهيل الجمعيات الصحية أنها توفر البنية التحتية عشان تدخل في المناقصات، علما بأنه نحن حصلنا على 4 استثناءات من الدولة على أن لا يكون لدينا لا ضمان بنكي أولي ولا ضمان بنكي ثاني، وما يكون عندنا متطلبات أنه لازم يكون عندنا تسجيل في التأمينات الاجتماعية بالكوادر البشرية، وأنه يكون في عندنا استثناءات في أولوية في الحصول على المشاريع اللي هي تبع الدولة أولوية.
So these are the kind of opportunities. I have to say, like, I'm not sure if some of the experts in the room, they might not be aware of that. If I was not involved in that workshop, I might have not even be involved. So sitting beside you is our beloved president of the Saudi Geriatric Society, and we kind of had maybe some talk about it. أمين المال بعد جنبه, we can do that kind of collaboration soon. So, Dr. Anta, were you aware about the depth of that basically initiative? Or have you been aware of about it before today's discussion?
صحيح, وذكر عدة مرات. والآن المركز الوطني لتنمية القطاع الغير ربحي تم يعني إنشاءه للإشراف على كل الجمعيات ووضع آليات عملها. واعتقد ان الامر قادم انه يسند بعض المهام الحكوميه للقطاع الغير ربحي، وهذا الشيء اللي حقيقه نتطلع له، وباذن الله يعني يسهم في انجاح مثل هذه المبادرات.
Okay, thank you so much. So moving forward, so that would be the fourth and the last part in that SWOT analysis that we just did. So strength, weaknesses, opportunities, and now we're talking about the threats. So from what we've heard today, let's say we come up with a national plan, a national action, basically items, priorities, and very specific objectives with a timeline, with ownership, with accountabilities, and we are reaching the implementation phase. So in that phase, you're in that time where you're trying to implement the plan. What do you think would definitely jeopardize and threaten the implementation of the or rollout of the action plan? Okay, so let's talk about immediate risks or immediate threats, so we can actually tackle them and try to eliminate them in the process, or at least predict them, so we can forecast how can we deal with them and basically develop a contingency plan to address these kind of threats. Okay. I wouldn't say increase the number of geriatric population is, the increasing number of geriatric population is the threat. Maybe I want to push the discussion towards more of a hyper-acute, let me use that phrase, hyper-acute phase. So in the next couple of months to weeks after we put the plan, what do you think would be the threats that we would face regarding the implementation? So is it going to be like a regulation barrier, or would it be, let's say, absence of expertise or workforce to implement this kind of plan? Maybe it would be like a policy that you know about that definitely would hamper the implementation of the plan. Yeah. Okay, so amazing point, yes. So from what I see here, I think we, from the themes that we have here, I think there is a very common agreement and basically a common theme that I see, that there is an issue regarding the accountability. There's also an issue regarding the coordination and either case coordination or coordination between the facilities, institutions, ministries, and so forth. And there is also areas related to the overlap of the national plans. So I think I know who would that comment. Okay, so maybe let's start with Dr. Abdullah again. So what do you think, from your opinion, the imminent threats for rolling out the national plan?
Thank you very much. I think accountability related to the care of elderly in general, and the component of the care of elderly, including Alzheimer's disease. Although the most recent law that was released, the accountability is very clear on the Ministry of Social Services. As you know, there was, always there is an issue between Ministry of Health or Ministry of Social Services, but I think the new law put it on the Ministry of Social Services in a very clear, in my view, language. In addition to that, I will add cost, which is a general threat, but especially in the field of the elderly, with the new, biologic, monoclonal, therapeutic intervention and new technologies in the field. Cost will be, I think, one of the barriers for this field, dementia in particular, but this field in general. Thank you.
No, I agree completely with Dr. Abdullah. So I would say right now we're noticing silos in different services across the kingdom, each working somewhat individually. And I think it would be a great opportunity to collaborate together, not only to avoid duplication, but also to bolster each other's services. Even today, when we meet as experts, we are recognizing what each of us is doing in starting these services. And I agree with your point in terms of just having that stigma or misinformation or misguidance, and investing in therapeutics that don't really work, or the evidence is still early in terms of biologics, as you said, and taking that funding towards something more solid and reproducible in the future.
So I think we can basically take another comment. If anyone has something to say, I'm more than happy. Yeah.
أنا أعتقد في مشكلة عندنا، وهي إنه الحقيقة ربما الدكتور وليد لاحظها. عندنا مشكلة إنه أحيانا الجهات ذات العلاقة والمسؤولية عن كبار السن وعن المرضى الدمنشيا عندهم مرجعية مختلفة. هذا عنده معلومات تناقض معلومات الآخر. لما تطلع لصاحب القرار يحتار يتخذ أي قرار، وهذا مشكلة الآن موجودة حتى الآن. أنا أقول هذه مشكلة كبيرة وأولوية، ولكن أنت لما أعرضها عليك تقول لا أنا مشكلتي تختلف. فما أدري، هذه أظنها إذا ما وحدنا مصدر الداتا والمعلومات المصداقيتها، أنا أعتقد أن هذا ممكن يؤجل القرار الصحيح من صاحب العلاقة ومن صاحب القرار حتى يتخذ القرار الصحيح ويعطي الدعم الصحيح.
So, Dr. Hashim, no? Allah yarda alayk. طيب, now we can move to the other part of this presentation. Oh, we still have like 10 slides more. I will cut it short, Dr. I will try to fast forward the discussion. اسمك معي. شو اسمه? Okay, so moving forward. Okay, what are the recommendations to address? Okay, so I think here we talked about the the action areas. I'm just going to go back to remind you regarding the priority. Oh, here it is. Sorry. So basically, we settled at that our first priority should be on dementia diagnosis, treatment, care, and support. So I will go back to this slide each time. And the question would be like, okay, now using action verbs, SMART objectives, Bloom's taxonomies, I'm using the Saudi Commission for Health Specialist theme here. We would like to come up with basically clear objectives for each action area. So we're talking here, we're gonna start with the first area. So if you can take a picture of that so we can come back to it. So now, like you imagine that you are in the writing committee and you would like to focus on this area of dementia diagnosis, treatment, care, and support. What would be your first like achievable, or maybe you can write one or two goals, and we're just gonna discuss them in that domain or action area. So we all agree here that we should focus on dementia diagnosis. How should we reach that? Do we, let's say, develop maybe excellent centers of dementia across the kingdom to help with the early diagnosis, for example? That could be one objective. We could also talk about access to care regarding like using like universal health coverage for all people with dementia in terms of all the anti-dementia medications, whether albeit like psychotics, antidepressants, cognitive enhancers, or whatever you think is there. And we have also some of our colleagues who work on pharma, so they can also help us with that. So we want a couple of objectives. I will go to the slides that will address that just now, okay? Just a second. Okay. Oops. Interesting. So I'm not sure if in your basically in your screen, can you please press enter to start countdown? Right? Oops. Okay. So here's the, you will have like maybe 2 minutes. And yeah, 2 minutes. You can just write your recommendation. So what's your recommendation to address the first area that we just talked about? Okay, so 1 second to go. Okay, so time's up. So basically, plan dementia centers. Okay, so basically there's no correct answer, or I mean every answer is a correct answer here. So plan dementia care centers, expansion on catchment area, develop clear guidelines to translate culturally, adapt diagnostic tools, standardize the cognitive assessment, and enriching the Arabic content of public awareness. I have to say these are amazing points, and if I actually would say something, I would first would like to focus on ensuring the availability of community-based services for people with dementia, and that can be in the face of either social type care or medical care. So most of the care of people with dementia happens in the community. It should not happen in the secondary or tertiary unit. So all the community services, like the other thing is that we all know that people with dementia have certain needs, and they have certain social needs as well. So like an adult day center for people with dementia, something that I really miss here in Saudi. I understand that there is an adult day center for people with disability, but maybe we can hear about the availability of such service here in Saudi from Dr. Talat. Do you know if there is any adult daycare centers for people with disability, اللي هي الرعاية النهارية, and your experience, and how could we actually utilize that? Because like most of us know that people with dementia, they get bored. We need to engage them in the community. Part of their treatment actually is to engage them. So do you have anything to say about the adult daycare centers and the initiatives that you have?
دكتور هاشم هنا معنا. هو لا شك انه في الان جمعيات تعنى بكبار السن. اظن في عندنا دحين اظن 12 جمعيه كبار السن. من احد مستهدفاتها تعمل مراكز رعايه نهاريه لكبار السن، نوادي موجوده. ممكن في الان موجود، ولعله في الان اكبر مركز افتتح في الباحه، مركز اكرام في يعني في جده وفي المدينه. اللي بدي اقوله طبعا هذه جهود القطاع الغير ربحي اللي بيساعد. بالنسبه لل الوزاره عامله طبعا ترخيص اداره، والاداره تطلع التراخيص انك تفتتح مركز ضيافه سواء للكبار ولا للصغار. فهذه مشجع القطاع الخاص انه يفتح مركز لكبار السن. اعتقد انه هذه احد الاشياء اللي هي تساعد. زي ما ذكرنا انه انا اعتقد انه الخدمات الاجتماعيه هي تفوق وربما او انها دوميننت على الخدمات الصحيه، خاصه للناس اللي نط سفير لي دمنتك.
The other thing is when it comes to the availability of dementia treatment. دكتور تفضل. تفضل دكتور.
السلام عليكم. طبعا I haven't heard anything about like dementia adult day center here in Riyadh or outside of Riyadh. However, as Dr. Talat said, probably those who are going to benefit, those in the early stages probably. However, we still can consume what is available. Like in Riyadh, we are lucky to have King Salman Center here. And it's a great opportunity for all elderly to utilize it. Really, I visited many times, and every time I go, really, I feel so happy to see something like that. However, it's not being utilized well by the elderly. So I wish that we can have more announcement about it, or those who are taking care of older people in their clinics or in the committees to help to just to announce it to people to utilize it. والله تعالى أعلم.
يعطيك ألف عافية دكتور. This is a great point. The other area that goes usually under the dementia diagnosis, treatment, and support is the basic dementia competencies included in, let's say, curriculums or curriculas of medical education. I don't see that was addressed here, so I just wanted to challenge or steer the discussion towards that direction. So from your experience, do you see, like a lot of us here is in medical education, do you guys see that there is sufficient health education for undergrad or even postgrad students about dementia care or basic dementia care? And how can basically, where should we start from here? Like what we are here, like we're talking as a society, as a basically non-for-profit organization. How can we actually raise this to the decision makers, policy makers, and stakeholders to develop this item, please?
يعطيك العافية. I think that's an excellent point. I wish I'd put it up there. I think the step before that is to, first of all, have the actual service established, and then have those that can rotate in those services come visit. So I think perhaps even before undergrad, before even awareness, if we can have said services established for geriatric medicine or dementia centers, whatever that is, to have those in residency programs, psychiatry, neurology, family medicine, to rotate in them, initially as electives, but down the line should be mandated in mandatory rotations throughout their training, in my opinion. And in fact, the West are now doing so, at least in a lot of provinces in Canada. It's become mandatory for internal medicine residents to do at least a month of geriatrics, for example. And I think that's essential because they're going to see a bulk of dementia cases and not even knowing that they're dementia versus delirium versus depression versus normal age versus MCI. So I think it's paramount to have it in health education, at least in residency programs, to take as rotations, perhaps as electives, then mandated, and then spread it across to undergraduate studies.
Okay. So thank you so much. This is a really amazing point. Yeah. Here.
كليات العلوم الاجتماعية، الخدمة الاجتماعية فارضة على قبل الخريجات ما يجوا عندنا في دور الرعاية الاجتماعية رجال ونساء. فجزء من التريننج حقهم قبل ما يتخرجوا لازم يجوا يتدربوا. فانا اعتقد انه هذه بالنسبه للكليات الاجتماعيه. انا ما ادري اذا بالنسبه طبعا للطبيه هل هو في عندهم طبعا جزء لابد قبل التخرج انهم ياخذوا تدريب او يسموه يعني فولنتير وورك اجباري، لكنه هل لازم يروحوا مراكز كبار السن تابعه للوزاره. لكن عندنا من 20 سنه واكثر قبل ما يتخرجوا اللي هم حقون الخدمه الاجتماعيه يجوا عندنا في مراكز كبار السن والدمنشيا.
Great. يعطيك الف عافية دكتور هاشم.
في طب الأسرة عندنا في الرياض كل ريزيدنت عندنا فاميلي ميديسن كانوا بيجونا أسبوعين روتيتنج في الجيرياتريك سيرفيسز. دحين لما خلوهم 3 سنين بدل 4 سنين صاروا بيجوا أسبوع. فأتليست يعني التريني في الفاميلي ميديسن they get exposed للجيرياتريك سيرفيسز in particular dementia، لأن معظم البراكتس حقهم اوت بيشنت، فبيشوفوا جزء لا بأس به من حالات الدمنشيا. أرجو الله إنه المجلس العلمي حق الباطنة والسبورت حقكم يا وليد أنتوا الشباب إنه to add geriatric rotation في الجيرياتريك ميديسن، ومو شرط تكون مانداتوري، على الأقل مانداتوري إلكتيف أو selective. Yes.
So that's a great point. So from I think using that access اللي هو scientific committee, but also there are, because dementia is shared discipline, right? You have psychiatry, you have geriatrics, neurology leading that part. So maybe at least these related societies or related let's say discipline can put forward like a statement to the Saudi Commission for Health Specialists, for example, to at least have one selective rotation in the major residency programs to rotate either in one of those rotations. So I think that's an excellent point. So moving forward, Dr. who took a picture of areas so we can go back to them. عشان ما ارجع في السلايد حق الاريز كان فيها ترتيب الاريز. Yeah. Okay.
Thank you. Just one comment. I know it's mentioned there about having the Arabic, like the standardized cognitive assessment. So recently I needed to go and look up some studies about the prevalence of dementia in Saudi. And so to start with, the studies are very limited. But then again, when you look at the quality, like each study used a different test. Okay, and each one had a different cutoff point. Some tests that were used were not actually, like, they were not validated in Arabic. Okay, and then we have an issue with the illiterate patients, which now we're less than what they used to, but like we still have that as an issue. Like we need we all need to agree, different specialties, on what test we're going to use to diagnose, because you don't want this diagnosis to be, you don't want someone to be mislabeled as having dementia as well. Like we have seen it, like we have patients with advanced Parkinson who don't have dementia, and just because of their poor communication, they were labeled, or they have medication side effect, they're labeled as dementia, and you can understand what the legal issues that's going to follow this. So I think it's as important that we as a scientific community agree on how are we going to diagnose it, what are the standards, and this should be spread and should be the only criteria to you after agreement to be used as a diagnosis, because it's going to make a lot of, like, without a clear diagnostic tool, we're going to be in an issue.
Amazing points. Thank you so much. And I have to say, like, yesterday I was reviewing an article with Dr. Taim, who's not, I wish he's here today. We were looking at the basically diagnostic accuracies for blood-based biomarkers and other biomarkers, like for dementia. And what is really surprising, that clinical modeling still outperforms biomarkers. So the clinical modeling, either using AI or just a clinical model that predicts the risk of developing dementia, can predict the risk of someone 5 years, like from that time of assessment of getting dementia by almost above 85%. And adding like biomarkers like to that increases it only by maybe a couple of points. So, and if you, most of the studies that focuses on biomarkers would report the combination of biomarker and clinical, but for the very first time a study in neurology published both, so clinical prediction tools versus the biomarkers. So I think it is very instrumental at this point to focus on that point. And we also use technologies. Now, technology is definitely is going to be part of our daily life. And big data, even personalized kind of medicine approach. And you can always now predict your risk of developing any, like a lot of diseases, nevertheless dementia, by using your personal characteristics, genetic makeup, like ApoE4, for example, or other stuff, and some of the cognitive assessments. So that was a really eye-opener to me, reviewing that study, and I can post the link later on. So we discussed that the second priority area for this cohort of experts would be dementia awareness and friendliness. So I'll go for the, just because of the time's sake, we're reaching now at 5 p.m. Maybe I will not, basically I will give 2 minutes to discuss that question. And I will shorten the discussion a little bit so we can keep with time, okay? والله ما ادري كيف وصل هنا. Okay, so I think so for this second question, basically what should we do to address that second priority area? And to remind you, the priority area is basically friendliness and dementia awareness, okay? So most of you voted that this is an action area. So dementia awareness and friendliness is an action area that we should focus on. So what do you suggest we do to address that action area? Okay, amazing. So these are really textbook recommendations and amazing points. So educating the public, public campaigns, making education curriculum more inclusive, coordinate with the Saudi Alzheimer's Society for key NGO players, and health professionals, workshops, dementia awareness, and so forth. So amazing points. And just for the time's sake, I might not spend a lot of time discussing this, and we're going to move to the third action area, would be the risk reduction. But I have to say, like, I personally, from the Specialized Geriatric Service Administration and the Ministry of Health, just a few months ago, we were asked to come up with plans just for geriatric service in general. So some of the projects that we suggested was to focus on age-friendly institutions and age-friendly healthcare systems. Fortunately, this came up to the minister, which then escalated to the Minister of Finance, and based on the recognition and basically the acknowledgement of the importance of this project, it came down to the actual budget. So الميزانية العامة للدولة that وزارة الصحة أو وزارة الموارد البشرية وغيره يركزوا على المنشآت صديقة لكبار السن. Now it's already printed, and hopefully we can work towards that goal. These kind of recognition, although it doesn't come with the allocated budget, but still states that this institution should allocate some budget to address that, let's say, innovative, collaborative project. So, but I have to agree, like, with 100% with these recommendations. Most of the societies think that this is usually the right way. For example, the WHO would recommend to address this area, basically to help support the existence of a public awareness raising campaign, which I think the Saudi Alzheimer's Society is doing amazing work with that, and we will capitalize on that to fulfill that goal. Also, they recommend supporting the existence of dementia-friendly social and physical environment. So these are areas that has been addressed by the Human Resources and Social Development Ministry to basically make healthy cities, and this is a project that is already ongoing in collaboration with multi stakeholders, including housing department and other ministries and municipalities as well. And the third area that they would recommend that should be addressed is the support of dementia education / training for non-health care population groups. So, so that would be like supporting caregivers to know how to deal with patients with dementia in nursing home, long-term care facilities, and so forth. This is a multi-sectoral, let's say, multi-sectoral goal, and it should be owned by multiple people. But I have to say, like, it should be part of the licensing for anyone who's, let's say, dealing with a patient with dementia, that it should go through a course either by the Human Resources Ministry or the Saudi Commission for Health Specialists to at least be able to deal with the basic needs of people with dementia. As we know that a lot of people with dementia in homes, they can be ignored. We talked about that yesterday, and this neglect is now basically it can be punished by law. So you cannot actually bring someone who does not understand Arabic or even doesn't know that law without giving him the basic training. So I think it is upon us to basically help develop that kind of course for anyone who's developing. Because as we know, the women workforce is women workforce share is now increasing. And we do anticipate that the dynamics of our, let's say, houses or families are going to change with time. Now we do have this health dividend that we know that a female is going to take care of us when we get older, our sisters, our daughters, but later on it's going to be upon the caregivers, the maids, and even the older adults themselves. So being ready for that new reality, it has to come with responsibilities, and I think we should actually capitalize on this moment. If you guys have any comments, or I think it was a long comment from me, but if anyone has to share something, or we can just move ahead to the third question. لا تقول دبلوم والدكتور فهد يعني. في maybe we're not going to talk. So what we are focusing on now in the Saudi Commission for Health Specialists, especially when it comes to these kind of programs, we develop something called professional development programs. That would be like a year or below. But you know, the problem with diplomas has some, it comes with a lot of expectations, and a lot of things can be built on just being qualified as a diploma graduate. So it can create a lot of issues in the future for those who comes like trainees who did not finish training in family medicine, internal medicine, and then they just like I had the home care in the Ministry of Health. And a lot of my colleagues just joined this program, but they just graduated from medical school and then they finished 2 years, and they would seek to be promoted as a consultant later on after 3 years, and this is going to be a big obstacle. So there might be later on a revision of this program. I'm not sure really, but it is currently existing. There are people who are already in that program, and hopefully we see like light at the end of the tunnel when it comes to that, or restructuring of that program. But I think the Saudi Commission for Health Specialists has put forward amazing initiative, which is called the special programs, or الخدمات المختصة. Yeah. Okay. So I think we should capitalize on that initiative. إنه يتسوى program أقل من 6 شهور أو أقل من سنة. وبعدين you get trained in it and you get some sort of certificate that's less than a diploma, but at least gives you the knowledge that you can utilize to deliver the right care. Okay. Okay. So now I think we are approaching the latter part of the discussion, and although we have 7 action areas, I'm going to close the discussion for that part at the risk reduction, and we can conclude thereafter. Okay, so let's start that. So what's the recommendation to address this action area? And the action area was risk reduction. So what should we do as experts to address the risk reduction action area in our national plan? Like, for example, we can talk about like restructuring the community. You can talk about the 40% attributable risk or hazard risks for the most common diseases that can cause dementia. For example, we talked about immobility, we talked about diabetes, we talked about obesity, we talked about hypertension, and also in the Saudi community we do have very, very high rate of illiteracy for older adults, especially females. As we know, like dementia is more prevalent in females than male. And we should address areas that we think is basically specific to our community, specific to our nation, to address in that field. Okay. يعني في الجزئيه حقت الورك فورس maybe we will talk about the gaps اللي هي ايش توقعك في الجاب في المان باور. يعني انا في الجيرياتريك اعطيك النمبر عندنا 1 جيرياتريشن for 52,000 صعيدي ركيب. البنش مارك العالمي 1 in 4,000 1 in 5,000. شايف الجاب؟ يعني اشياء زي كذا. Okay, so what are the recommendations? So put an objective for decreasing prevalence by 50%. This is really a great, ambitious target, and these are the kind of targets that it has to be like time-bound, specific, measurable. These are the things that most of the action plans would like to have in them. And I think for this, I would like to get your opinion, Dr. Muhammad, about the risk reduction. Like from your experience, what we should focus on in the National Action Plan to reduce the risk of dementia. So here you go.
As my colleagues have alluded to earlier about dementia being reversible up to 35 to 40% according to studies that we've seen. So I think that's a substantial number if you look at it that way. Some things you can't change. Sunnat al-Hayah is to get older, which is the biggest risk factor. You can't change that. Genetic mutations, you can't change that. However, a lot of things you can remedy and reduce. It's not surprising to me when yesterday we talked about how the prevalence is increasing 6.4% in those ages above 60. So things to tackle. A quarter of our population, if not more, are diabetic, hypertensive, dyslipidemic. I think that alone, if we focus on, is a big initiative to counteract. No matter what we do in terms of education and providing support and services, if you have patients who are uneducated, depressed, obese, not exercising, smoking, with the HbA1c 15% and hypertensive at 170, no matter what you do, you're not going to counterbalance their dementia. And even then, even if they do have dementia and you don't address those risk factors, the progression is still going to get worse at a faster rate of decline. So regardless of what we do, this is essential to counter.
Thank you. Just wanted to add that most of these risk factors, and this is the good news, the Vision 2030 healthcare transformation is focusing on these, trying to reduce the prevalence of diabetes, hypertension, hyperlipidemia, obesity, improving physical activity, reducing smoking, etc., etc. So we can work on this, but I think there is a huge work that is being done. I think we should focus on things related to dementia and reducing the risk of dementia, such as social interaction, engagement, games, intellectual games that is now fading in our culture, and more of the electronic games, more research into our culture actually, البالوت and الكيرم and I would expect that it will help personally, and I see it in some of my patients, to be frank with you. Diagnose them with dementia, early dementia, because they are, you know, professional in ballot. They take very long time in their decline. This is, and again, this is just observation. We need to focus, I think, on these interaction and encourage it within our society, as it's, I think it's being fading right now because of what's happening, you know, in the whole society. Thank you.
Dr. Mona, do you have anything, or yeah? Okay, Dr.
Assalamu alaikum. Thank you to give me this opportunity to talk about this topic, and I think one of the important risk factor decreasing is engaging with some physical activity. As a physical activity, helping to promote new neurons, which I will elaborate on it tomorrow, inshallah, in the lecture. Also, we start see some patient with a stroke with the age of 25 or 28, which is really dangerous to have some society with a big influence with the risk factors like hypertension or obesity, or has less of effort while they are in young age. So I think the solution will be investing in the young society to start well from beginning. After a few years, those young society will be elderly. So if they are engaged with some physical activities or engaged with something like a neurological brain training exercises, we have a lot of applications help to stimulate the brain thinking. A lot of things, like the doctor said, that used now in the society, like gaming, or these will help a lot. But having more educated people starting from school about the risk factor, about how they are going to save their brains in future is important, I think, in this time.
So so basically, I think we are reaching the end of that part of the discussion, and moving forward, we're going to talk about supporting the workforce to become capable and become ready to support people with dementia. So in that part of the talk, Dr. Fahd, inshallah, is going to give us some reflections about where we should start in terms of preparing the workforce to provide care, appropriate care, best practices for people with dementia at all the levels of, let's say, the workforce, either professional or non-professional. And if from his understanding there are national gaps that we need to address when it comes to the workforce development, and from his previous experience in the Saudi Commission for Health Specialists, what would he like forecast for the future, given the global and the national increase in dementia prevalence? Thank you, Doctor. So that would be more of a short discussion between me and him. Tafadhal, Doctor.
Thank you for putting me in trouble. So he gave you a context. Why did he ask me to address this subject? So I'll address it briefly in a way that hopefully would make sense to everybody in terms of addressing this issue in geriatrics and in other similar probably areas. So the repeated story in Saudi healthcare system and outside the healthcare system is that usually someone call for more qualified Saudis in a certain field. And when that call is answered, people start to graduate. Then more people start to graduate. Then in new other places starts to open up and graduate. And then suddenly the market is flooded. So that has happened, as you all know, in dentistry, in pharmacy, recently with physiotherapy and lab medicine. So whenever there is a need, the lesson that has been learned from that is whenever there is a need for a qualified profession, that should come with a guarantee that they will be employed. Otherwise, there will be a flood of qualified, newly graduated, ambitious professionals who will not find jobs, either in the private or government sector. So now when we apply that same concept to geriatric services, which are, as you all know, are based mostly on professionals who had done geriatric as a second degree. There is no basic degree in geriatrics. All who work in geriatrics are either physicians who have done a major specialty, or nurses, or physiotherapists, and so on and so forth. So the focus would be on higher education to develop geriatric professionals who are able to provide service with high standards. Now, who is going to employ those graduates? Maybe now we think that jobs are available everywhere in geriatric services. Within a few years, that door might be closed. So the lesson that was learned, and it has been implemented in a variety of professions over the last few years, is that without going into very specific details, certain elements of the government will be interested in a certain number of graduates in a certain profession. They will address that with the Saudi Commission or sometimes with universities. That number of qualified professionals is guaranteed to be done as soon as possible. So it's a product. And then that manufacturing machine stops to avoid flooding the market with individuals qualified who will not find a job. That is basically the problem of producing qualified professionals in a nutshell.
So,
calculate, find jobs,
Yeah.
jobs that are created. Jobs that are created. We don't have those created jobs now, so the jobs have to be created. The numbers of needed professionals would have to be well done or made in advance, obviously with a acceptable level of margin of error. And then whoever can graduate those numbers would be able to do this as quickly as possible without affecting the quality of their training. And when that number had graduated, then this process is revised. Either we would have to continue graduating, but with probably smaller numbers, or we stop. And that has happened with, in my brief experience with the Saudi Commission, it has happened with few professions. يمكن سمعتوا الأمن الصحي وأشياء من هالقبيل. Then it stops. خلاص, the product has been satisfying. The numbers that are available are good enough. There is no growth in the sector, or the growth might be very minimal, and so the side effect of too much production is halted.
يعني أنا أذكر النقاش كان قضية وجود الأطباء المتخصصين في طب الشيخوخة هو ضمان. عندما أنا أريد أن أبني الانفراستراكشرز لكل الباراميديك المتخصصين الذين يعملون كفريق متعدد التخصصات يقدم خدمة لكبار السن اللي عندهم أمراض مزمنة وكذلك عندهم ديمنشيا، وجود السوبرفايزر والمونيتورينج يضمن انه اللي يتخصصوا واللي يتدربوا يكونوا عندهم التريننج المناسب وعندهم المهارات المناسبة اللي يقدموا بها. فإذا كان عندنا وضوح في الرؤية على العدد اللي موجود والموزع على المؤسسات الحكومية الصحية وعلى البوبوليشن، واضح انه نحتاج ب 20 50 ولا 30 يكون عندنا عدد اللي عندهم امراض كذا ونحتاج كذا. ايش اللي يمنع انه ما يتحدد العدد ثم ناخذ موافقة اصحاب القرار انه نكريت هذه الوظائف؟
لانه اللي المفروض يحدد العدد كان كسول جدا في انه يحدد العدد. فاذا ما حدد العدد معناته ما في التزام بالتوظيف او بالاستفاده من الخريجين. فالخريجين تعلموا الدرس من الدفعات السابقه. And they started to know that this is a risk. They might graduate and not find a job, or find a job that does not meet their ambitions, or the job are not as paid as they thought they will. They might have well done something else, probably better off for them. So that story has been going on and on repeatedly for a few generations now. من البومينج حق التدريس إلى البومز الأخيرة في الهيلث كير. That's the risk.
Dr. Fad, are you aware of any program to basically teach caregivers in the Saudi Commission for Health Specialists with a certain degree or no, just like a caregiver stream kind of مقدم رعاية صحية. أتوقع there is a new like a specialty or something like that that was agreed by الهيئة. And what would be the role, and how could I in home care and Ministry of Health employ these people? Because we are really looking, we don't want to have just a qualified nurse. We just need caregivers, people who are going to assist with the ADLs, activity of daily living, and so forth. Yeah.
So the Saudi Commission primary objective when it comes to education is qualifying programs. البرامج اللي تخرج متخصصين. Programs that develop someone's skills come under a different umbrella. We have our conferences, CME hours. We have what we call short professional programs that are usually of about 3 to 6 months, يعني full-time or part-time. For example, there are programs that teach nurses how to manage end-stage renal disease in dialysis settings. So those are programs that teach them new skills or privileges or improve their current privileges, but it does not take them away from their profession or their specialty. Anybody can develop that program, apply for it, get it credentialed, and then provide it as a service to whoever they want. But I'm not sure if more recently have been any approved programs in this regard. As far as I remember, there wasn't.
There was also, not only that, there was also a specific title في وزارة الموارد البشرية Human Resources for caregivers and caregiver support. If you are aware of that, or yeah, تفضل.
يبدو لي انه تقدمت بعض الجمعيات العلمية بكوريكولم عن طريق القطاع الخاص للوزارة عندنا، بانه بدل ان اجيب عامل، عندنا العقد 3 سنوات 2 مليار للمراكز حقت الإعاقة وكبار السن، فقالوا نحن we give you safe caregiver انه عنده باك جراوند الامور الصحيه تمثل 30% 40% والباقي اجتماعيه، they just teach him how he deal with transfer, cleaning, bathing, feeding. واعتقد انهم اتصلوا بالجمعيه الصحيه حقت الرعايه الصحيه المنزليه العلميه وجلسوا معاه وسووا كريكولم حسب ما اذكر لما كنت في الوزاره، بس انا ما ادري، فهمت انه عرض على الهيئه السعوديه للتخصصات، ما ادري تتذكروا انه ما تذكر عن الموضوع، وعشان كذا انه بعد كذا الشركه صارت تستثمر في السعوديين، تاخذ الخريجين وتديهم برنامج ذا.
Like for me, basically, for people who are providing home care, we really need to have qualified people providing care for like end-stage problems, nevertheless people with dementia. And my understanding is that there is a recent approval of a program from the Saudi Commission, and I saw like a couple of, let's say, brochures about it, but I'm not sure about the exact title they give them. But I know that it is coming very soon. But other than that, let's steer the discussion in another direction. Dr. Muhammad, from your experience, what other workforce qualities or workforce competencies or skills or maybe even let's say disciplines that has to be developed to provide the appropriate care for people with dementia across the whole journey of people with dementia. So not just focusing on the end stage or home care, like from the whole, like we have neurologists, geriatricians, we have psychiatrists. What else? Like what would you like to see in the workforce or the bodies that develop workforce, so we can have like a comprehensive care provided for these people?
That's a very challenging question. Thank you for putting me on the spot. if I'd had to pick one, and there's many answers to this, I'd say nursing. You talked about elderly initiatives وكيف تكون مستشفيات صديقة لكبار السن. So having nursing skills and nursing care geared towards geriatric medicine, I think would be very essential. I think الحرس الوطني has a few programs. جامعة المير نورة has a formal nursing training program now for geriatric medicine. So I think it's starting. I think that's essential because A, there's a lot of nurses, and B, they can propagate and proliferate that culture, especially in hospitals, right? When they come into hospital, you can have them being aware how to deal with dementia patients and cases, change their environment there to make it more elderly friendly, and discharge them hopefully sooner. And by that, also tackle the part you mentioned about caregivers, right? And so I think it's a win-win. If you teach them, they will then propagate that to caregivers down the line.
I have to also say that we also need to capitalize on family members, because most of the care is provided by family members, and educate family members, not like through formal training, but at least having, let's say, modules available for them that can potentially support them. So that could be part on either scientific committees, NGOs, and other parties. Dr. Hashim, أنتوا عندكم like a day on training nurses or something happening in the National Guard you just heard in the news?
Yes, thank you very much. Yeah. عندنا أخي الكريم برنامج متخصص لتدريب التمريض في inpatient services في geriatric services established last year. Very يعني comprehensive, active for acute geriatric care, and approved. يعني it's like a workshop. يتعمل 3-4 times per year, and approved by CMEs from Saudi Council. Yes, الحمد لله. بس حابب أضيف نقطة. مجلس شؤون الأسرة يا دكتور طلعت في أكثر من مبادرة لسه حتتعمل. طمني عنك، ومبادرة ثانية كمان الهدف منها تدريب مقدم الخدمة بإذن الله تعالى، وحتصير إن شاء الله تعالى، وعلى وعسى حتفيد إن شاء الله تعالى. شكرا.
انه بس نحن نقول نبغى فقط الدمنشيا.
لا
اتوقع إيه. لكن لما نقول انه الاخصائي او الفني الرعايه الشخصيه او المنزليه في البيت، طبعا اول شيء نستهدف فيها الاسر والاهالي اللي قادرين ندربهم، لانه هذا اول ريسورس قوي للاسره عشان تقوي فيهم الرباط والبر والهذا. لكن لما يكون حاله صعبه جدا، هي قضيه انه ممكن يدخلوا فيها الاسيستنت نيرس اللي ممكن يقدموا الخدمات النيزوغاستروكتوب والتراكستومي والاشياء هذه. لكن اعتقد انه السؤال انه الان عندنا برامج مختلفه هنا وهنا وهنا. ليتنا لو قدرنا نجمع الموجوده الان والمبادرات في الجامعات والمبادرات هنا ونسوي شيء براكتيكال، بلاش تو ماتش نولج اكثر من اللازم، اوفر، او انه مهارات اكثر من اللازم ويصير في تشتت. لو نركز على شيء، اول شيء لازم وزاره الصحه تعتمدوا مع الهيئه السعوديه التخصصات، لانه لابد يكون سيف وعنده المهارات بحدها الادنى. اما انه التشتت ممكن ناخذ فيز 1 وبعدين فيز 2 اذا كان يبغى واحد ادفانس، لكن خلينا نبدا الان بالاساس.
الله يرضى عليك. So I think we've reached to the end of this I think 2 workshops that we concluded, and hopefully we are on time. We kind of skipped a break, so I would like you guys to first to thank everyone who came in today, spending with us over like good 5 hours here, discussing very important topics. I would like to thank my co-moderator, Dr. Fahad, and all the speakers from today's session, and the audience and attendees, and all the organizers, and the people in the back. Shout out. ممكن تنزل الأغنية مرة ثانية حقت Go Back to Business. Otherwise, I'm really honored to be working and learning, and hopefully trying to put something that is useful, something that's actionable, and with the ownership that's clear, inshallah, in the coming few months. يعطيكم ألف عافية. Thank you so much.